Officer, and myself, Claudia, Deputy Education Officer. Just a quick introduction. This is the first time that our branch organizes an event in this format. So we would really appreciate your feedback at the end. We will send a form to all attendees. This will help us organizing more of such events in the future. And now, may I welcome and introduce our expert panel, who will be answering your questions. I will start with Jenny Wilson, who's our IPS Vice President, Professor of Healthcare Epidemiology at the University of West London, and IPC nurse by background. And we have Katie Jeffrey, consultant in clinical infection and director infection prevention control at the Oxford University Hospitals. Peter Hoffman, who is a consultant clinical scientist at PHE, Public Health England, and IPS member. May I ask, please, who has the microphone on, if you could silence it, please? Thank you. Then we have Martin Kiernan, who's the clinical director of Gamma Healthcare and IPC nurse by background. Alexander Hills, charter member of the British Occupational Hygiene Society and regional industrial hygienist for Shell. Paul Humphrey, charter member of the British Occupational Hygiene Society, consultant and trainer in the assessment and control of hazardous substances in the workplace. He's also Fit to Fit accredited on fit testing and member of the Fit to Fit technical committee and owner of the company Dust to Noise. And Stuart Airy, advanced application engineering specialist for 3M. So that's enough for me talking. Now I will start with the first question, which I think Jenny will be answering with the eyes. The first question is, shops are checking customers' temperature on entry, yet we don't in hospital. Why?
Yeah, that's a very interesting question. In fact, I was in a hospital earlier today and they were checking the temperature, but it was a bit like you get in some airports, particularly in Asia, where it was a sort of archway that you walked through that had some temperature reading at the top. And it sort of seemed to me that the people at the desk who subsequently asked you what whether you had any symptoms and issued the alcohol gel were taking no notice of what the temperature was saying. Perhaps could somebody turn their microphone off? I think somebody's still got their mic on. Perhaps you could turn that off. And I think that illustrates a couple of things. First of all, that it's quite a complicated thing to do in an accurate way, and if it's not accurate, then perhaps it has little value. I actually think the other problem with temperature testing is that the thing about a fever is that it comes and goes, and so you would need to actually alight on that person at the point that they had a peak in temperature at the very moment that they're presenting at the hospital. And it seems to me that that's highly unlikely, or there's a very minimal chance that you're going to do that in any effective way. And actually we are better to look at the broader range of symptoms, because we know that people with COVID, they will present with a wide range of other symptoms, and we're better off focusing on symptoms that they may have and excluding them in that way. I have to say the other things about shops is that they're really just trying to do what they can to reassure their customers, and many of them are advised by a wide range of different people who perhaps are not so expert as in infection prevention as we are.
Yes, that's a very good point. Thank you, Jenny. I wonder if anyone else would like to add something.
Only to say that I had mine checked recently when going into an office, and I've been kept standing outside the door for a couple of minutes in the freezing cold draft, so my temperature was 34 degrees when I walked through the door. So I'm surprised they didn't wrap me in a thermal blanket when I got in there, if they're going to do something with that number.
Very interesting.
No, they don't really care if you're cold. That's irrelevant.
And I was thinking as well, someone could easily take some paracetamol before going out, and then the temperature will also drop. So it's it's not really reliable, isn't it?
No, indeed. And in fact, my biggest problem is that I'm always drinking coffee. So if you took my temperature with a thermometer, a mouth thermometer, I'd always have a temperature. And really the electronic ones, especially the ones you walk under, I've failed to see how they could have any reasonable accuracy.
Okay, thank you very much. I think we will proceed with the next question. I will hand over to Chris.
Hi everybody. Yeah, so our next question is really focusing our minds around preparing for a second possible wave. And in respect to that, we found that Oxford have been doing some research which has shown that staff are using high-level PPE in high-risk areas, so the full PPE kit that's available at the moment, and they were more protected than staff working in medical wards, well that's the perception at least anyway, who wore surgical masks as opposed to FFP3 masks. So the question is around, does this mean that we should be recommending high-level PPE in all cohort areas during a possible second wave? And I think if I can draw upon Katie Jeffrey and maybe Alex Hills in the first instance to give us a bit of a response to that, and then we can open up wider.
Thank you, Chris. So, Claudia, perhaps we could circulate the preprint for the paper that we've put together after the meeting. But we took advantage of DHSC permission to actually do antibody and PCR tests on 11,000 of our hospital staff, and we were able to get data from them as to what area they worked in. And we found that overall about 20% of our patients who work in so-called COVID-facing parts of the hospital were either antibody and or PCR positive. But actually, when you looked at staff who worked in high risk areas, in other words, ITU or respiratory HDU, probably only 6 or 7% were positive. And so a very simple interpretation of that is that level 2 is better at protecting you than level 1. But I'd ask you all actually just to think back and think through the story of, COVID presenting to hospitals. When we first started seeing cases end of February, March, and up to sort of the peak of the COVID pandemic for most of us, certainly in the Southeast, around the beginning of April, actually we were seeing a lot of elderly patients who were presenting not with cough and with fever. They were presenting with diarrhea or delirium, so they weren't being identified as having COVID. They didn't meet case definitions for having COVID, so we weren't testing them. But we were admitting a lot of these elderly folk onto our medical wards. And I think a lot of our staff around that time were getting COVID without any PPE. On our actual acknowledged COVID-facing wards in Oxford, our staff were relatively protected versus those staff who were working in other areas of acute medicine that weren't regarded as being COVID facing. So the first thing I would say is that actually large numbers of our staff had no protection at all when being faced with COVID early on in the pandemic, before we were identifying and testing atypical presentations in the elderly and before we had universal wearing of PPE. The other thing that I would say about PPE, and I think it's something we can learn from, certainly on our ITU in Oxford, we were very lucky in that we had medical students supporting donning and doffing for all staff going onto our intensive care unit. We had staff working just in 2-hour shifts, and then they would come off again, so we didn't sort of get PPE fatigue, and as they came off the ward, they were observed doffing. And that was done right from the very beginning. We also modelled the sort of exposure on each unit to COVID based on the date of the first positive PCR. And it's clear that exposure on our acute medicine wards is probably much greater than on the ITU wards, where things were a a little bit quieter, patients were a little bit further down their journey, but a lot of training, rigor, practice. They've done a lot of simulation, so they just got it right. So I think what I learned from that is not that we need to have all staff in COVID facing areas in level 2 PPE, but that we need to get the training right. We need to have PPE in there in the first place. We need to be testing our patients on admission and testing them regularly throughout their stay. And we need to be sure that we're using our PPE appropriately and correctly and supporting each other. So I'll stop there because I'm sort of halfway through the allotted time. I'm sure others will want to comment.
Thank you very much, Katie. Can I just draw on Alex Hills then, please, to pick up around the element in particular around PPE and the different levels and your opinion around that, please?
Right. Cock off at the wrong time there. No, I mean, I think Katie's given a very sort of comprehensive answer based on the sort of specifics of the question. I guess coming at it from a more sort of health and safety type perspective, I think as with anything really, it's very much has to be risk based. And in PPE, as we all know, is the last resort. But if it's deemed that that's necessary, then you have to decide, how significant is the risk and the likelihood of exposure. And therefore, whether you actually want PPE that has a designated protection factor, the FFP3 or 2 type masks, or the surgical type mask, which I don't believe has a formal protection factor and is primarily there to protect other people from a wearer, as opposed to protecting the wearer themselves. So I think if you're really wanting to protect the people who are involved and there's a fairly high risk situation, aerosols, close proximity, etc., then it should be a sort of designated, approved PPE mask as opposed to a sort of face covering. And that, as I say, I think that'll be a judgment call as part of a risk assessment. I think you also have to remember, which will probably crop up again, if you have a valved mask, a mask with an exhalation valve, which can help to ensure sort of comfort and ensure good fit of a mask, but that can also mean that you can potentially be infecting other people with your exhalation. So you'd have to have everybody in the room would have to also have PPE. Yeah, so I think basically it'd be very much risk-based, and you select the level of PPE to the protection that you want to have.
Thank you very much. So at this point, I'd like to open up to the rest of the panel of experts we have on the call, please, to see if there's anything further that you'd like to add to this, please, for the members.
One thing I would say is that Imperial published a paper a couple of weeks ago, which I think maybe adds a little to that scenario that you described, Kate, because they were looking for COVID in the environment and in air samples. And actually one of the things they found was they found less in the ITU. They were not able to actually grow any COVID from any of the samples that were positive PCR, but they found less in the ITU. And one of the conclusions they drew was that many of the patients in ITU, or most of the patients in their ITU, were not having the same aerosol generating procedures as you may see in some of your medical ward cohort areas. So they were tended to be patients who were ventilated on mechanical ventilation, and so there wasn't that high level of ongoing aerosol generating procedures. So perhaps that's part of the factor that explains some of those differences as well.
Yeah, I mean, I have to agree with that. I worked at the Nightingale. Patients were 3 weeks, 4 weeks into their COVID journey. I suspect there was very little viable virus kicking around there, and yet we were burning through the most protective PPE because the whole place was an AGP area. And it did go through my mind: have we got the PPE around exactly the wrong way here?
Yeah.
And it should be at the front end staff, where the people in the most acute phase who just more likely to have environmental contamination. Unfortunately, they wouldn't let us sample the environment, but I'd love to know how much viable virus there was actually in the environment.
Yeah, I mean, certainly it was quite surprising in the Imperial study that they didn't find any viable virus. And I think that's another factor, isn't it? That there's a lot of aerosols produced, but certainly in an ITU setting, those aerosols, you may find virus from a PCR perspective, but actually there's a lot of dead cell being shedded from the respiratory tract of those patients. So in many senses, it wouldn't be surprising to find, as you say, an ITU environment, PCR, you may find it, but it doesn't necessarily reflect live infectious virus particles.
Can I just jump in very quickly and say there's a couple of comments in the chat around the role of masks, which were just touched on as well in terms of level 1, level 2. And at least from my perspective, surgical masks are not PPE because they do not meet any recognized level of respiratory protection for the wearer, nor are they approved to the PPE regulation. A type 2R surgical mask does have a fluid resistance claim to EN 14683. It is a level of protection from fluids to the wearer, but the function of a surgical mask is what you might describe as source control, or using the hierarchy of control, a sort of an engineering control to limit exposure at source. So there's a lot of confusion around masks and respirators and their role and function, and even approvals, and that's perpetuated by social media as well.
It's a very difficult area in that surgical masks are medical devices. They're not PPE, but they do have protective functions. What I'm finding is that the traditional definitions often don't hold true for these things. Something can be both a medical device and PPE at the same time, or it can function as PPE but can't be classed as PPE.
Yeah. Well, we may have to differ. As somebody who's tested surgical masks, they're tested to protect in exhalation, and they do have a level of filtration, yes, but they do not have any recognized form of respiratory protection. So it's a debate we could carry on for the entire hour, I'm sure, tonight. So maybe we'll just move on.
Not respiratory protection, but they do protect against splashes and droplets.
Absolutely.
Yeah.
There's a level of protection there, but it's not, you can't really quantify it so well. Yeah.
Thank you very much. In view of the time, I'm going to move us along to our next question. Jojo, are you on the call?
Yeah, I am. In line with the discussion that was just on regarding, but this one is specifically on the sessional use of gowns, okay? There were some cases where in sessional use of gowns have been linked to MDRO outbreak in the ICU during the pandemic period. So how can we prevent this from happening again? I'll ask Jenny Wilson first, and then we'll ask Martin.
Thank you, Jojo. Yeah, so many of you may realise that this has been a big concern of mine because I have been working as an honorary ICN in a London hospital where we saw quite a major outbreak of multi-drug resistant Klebsiellas. It's difficult to know whether the transmission was because of the gowns or the gloves or the approach to gloving. And I think one of the huge problems that infection control faced in dealing with COVID was a huge amount of information coming at staff and the difficulty in controlling the infection control advice and making the infection control voice heard. And I think particularly around the sort of doffing and donning that Kate was talking about. And certainly what was happening in this ITU was that the donning was done in an ante-room before entering the ITU, and then that PPE would remain on that person for the whole of their shift. I'm interested that Kate said you were working really short shifts, and I think that's probably really important because if you're only doing a 2-hour shift, you would hope that you would just stick to one patient and not move from one patient to another. But in longer shifts, that tends not to happen. And that obviously means if you've got a gown on, that gown is going to have contact with more than one patient. but the same would apply with gloves. If gloves are put on and perceived to be PPE that is put on and never taken off whilst they're in that high risk area, then clearly there is a huge risk that you're going to transfer pathogens around between patients. I actually think one of the bigger problems is that once staff put PPE on like that, then they tend to touch a huge amount of items in the environment. So you would see people sitting at the desk holding phones, touching computers. The computers on wheels would just automatically be almost hugged by people in their gowns as they sort of lean over them, touching them with gloves. So really, we need to go back to the basic principles of infection control, some of which I feel were sort of thrown out of the window in our concern about COVID and protecting staff. Sure, with also the additional problems of shortages of PPE, we lost some of those basic principles of infection control, which is PPE is for single use. And even within the same patient, working between dirty tasks and clean tasks, it's essential to take those gloves off and wash the hands. And we need to be really concerned about what we're doing with gowns. I'm not quite sure what the solution is. I know of one hospital that actually cut the sleeves off the gowns, given that the sleeves are the part that have most direct contact with the patient. And it strikes me that we really need to look at developing products that avoid the need to do that. So to look at short sleeved gowns that are make it much easier to wash the hands and forearms, the part that has most contact with the patient, if we believe that gowns are necessary in this situation. And certainly if that's not possible, we really need to look towards not moving between patients with the same gown on. I don't know.
Thank you very much.
What your experience at the Nightingale was, Martin?
Okay, so sort of a unique experience really. The whole place is ITU, and we had one critical care nurse per 6 beds, which meant we had somebody who was definitely not a critical care nurse at the bedside, who could sometimes be somebody out of a pharmacy background or a physiotherapy background. And then we had training teams going around, and we had washing teams going around dealing with the basics. So it was just somebody who was there at the bedside effectively. So we had some people who were static and others who were moving very rapidly from person to person. And what we tried to do, because the problem was we had no water in there really, we had some cold water. So hand hygiene was going to be very difficult anyway. So we had staff going in a gown, a long sleeve gown and a pair of surgical gloves. And then at the bedside, they were meant to put on a plastic apron and a pair of gloves over the top. And so the base layer was to protect them. And that I ended up making posters saying this PPE is just for me. Because what we found at the beginning was a lot of people were putting on the base layer of PPE thinking that's just my PPE and then flitting around all over the place. So what I would say is education is absolutely crucial in getting people to understand exactly what the PPE is for and which type of PPE is protecting whom. And I'm not sure we got that message over particularly well right at the beginning, but we did by the end. What I would say is we didn't have any MDRO outbreaks, mainly because we adopted the Donald Trump position of not looking for it. We did have one bacteremia with an MRSA, and we screened people and we didn't get anything, so that was comforting. And we didn't have any C. diff, which was also fortunate. But you know, education was absolutely crucial, and that's one thing that's taught me about this. Suddenly you're going to have people working in a critical care setting who aren't used to working in that setting, and they're not really getting that they're dealing with all these intravenous devices, etc., and they don't get the risk. And that's a really crucial thing. And there was actually a very nice paper just published in the Green Journal, actually, from George's, looking at what happens, and PPE was one of their issues. They were actually wiping down their gowns. As it turns out, we didn't actually use sessional gowns. We had plastic aprons at the bedside, but the gown was for that part of the shift. But people were doing 4.5 to 5 hours at a stint in their 12.5-hour shifts. And you know, we had a separate donning and doffing area because of the volume of people going in and out. It would have been very difficult to actually store the gown so that the person would go back to the right gown, and they would probably be going back into the storage area when other people were trying to get in. We felt it would really complicate things. So we actually took the choice, if we thought we were going to be short of gowns, to actually launder some gowns, because we thought that would be less risk than actually trying to keep them somewhere and take them off in a way that you would not contaminate yourself when you're putting them back on again as well. Was an issue. So I think education is really critical there. We have to get in very early and make sure that people understand exactly what the PPE is for and what they're supposed to be doing when, because they really didn't get that. And maybe we have to be a little bit more flexible about thinking about actually how people operate, because it's all very well for us to sit and write a policy, but we're not actually doing it. So I think what we need to do is sit down with, if there is a quiet period, sit down with the staff in critical care and say, this is what we would ideally want to do, and this is why we would want to do it. Well, what's really practical in the real world, and what can we actually do, and then negotiate some sort of settlement way forward.
Yeah, and I appreciate you had sync issues, but we fairly rapidly moved to only putting gloves on at the patient's bedside on the basis that, the virus doesn't go through the skin and the gloves will transfer it around just as easily as the hands, and that it was far more important to ensure, wear gloves for direct contact with the patient, but then you take them off and wash your hands or gel your hands. And so that stopped the use of gloves for handling shared equipment like computers and phones and desks and what have you, which I think is really critical. And, to me, it would be really good if we could re-look at that donning and doffing for respiratory viruses. It's not the same as Ebola, where you're talking bloodborne viruses, and exposure of blood to any microabrasions on the skin is going to be an issue, whereas with respiratory viruses, it's a little bit different.
Thank you very much, Martin and Jenny. Can I hand over to Lisa now for the next question?
Thanks, JJ. If, like us, you've had in your trust at least 5-6 different FFP3 masks, and you don't have a steady supply of FFP3 masks coming through, how do we sustain fit testing? I'm going to ask that of Paul and Stuart, please.
Yeah, I think basically we do need a steady supply. Probably everyone's aware, every time you change from a make a model of filtering face piece, you need to do another fit test. Every time you change it from the same manufacturer, you need to do another fit test. So 5 months, the NHS
Paul, I think we might have lost you.
has done far more fit testing than it needed.
Yeah, I think we've lost Paul.
We've lost Paul.
Am I back?
You're back. You're back in the room.
So that was really good timing, wasn't it? The one time I had to answer a question and I completely...
So I think we caught about 3 of the 20 words, but...
Okay, so great.
Sorry.
It's probably because my kids are downstairs, on their sort of games machines, but it's normally quite a sustainable link. If that happens again, I will connect with my phone. But can you hear me at the time being?
And now?
Yes.
Yes. So I'm coming through loud and clear. Okay. So I'll start again. I was pretty much saying that you did need a sustainable sort of supply of FFP3s. I was saying that I think in the last sort of 4 months, the NHS has done, way too much fit testing than necessary if it did have a sustainable sort of supply. So I obviously haven't been in all the sort of different trusts across the NHS, but my kind of impression from the few that I have sort of done training for is that there's been one fairly consistent sort of respirator, but then some of the alternatives have kind of just run out at different times, and a new one has turned up. And that is obviously a big headache, because it means that everyone then needs to be fit tested, in this new respirator. And some trusts that I was working with, they were just fit testing everyone in all their alternatives. So even if they passed in one, they would be doing another fit test in or the alternative, just in case they all sort of ran out at a particular time. So I think it's up to the government to actually, you know, it's allegedly in the media, it's been, you know, actually putting contracts out at the moment for new PPE. And it would be good to have a large supply or stockpile of a consistent make and model, and a few kind of options as well. Another thing I think you can do once you've got that supply is you can kind of behave a bit like industry behaves. So when they get some new starters, you give them a fit test as soon as they sort of come through the door. And you also do repeat fit testing. So after a period of time, say 2 to 3 years, you repeat all your fit testing. So you're always kind of in date. My impression from sort of some trusts, and it hasn't helped with this sort of lack of supply, but you know, there's obviously a lot of attention when there's a virus around, but then when that virus goes, the sort of fit testing kind of goes down the sort of priority list. And it may be, with all this attention and requirement for fit testing at the moment, it may be a good time to sort of think about having a role maybe for RPE or PPE, where people sort of manage this for you and make sure that everything is sort of running like clockwork. So when these viruses do come along, you're a bit more prepared. Okay, I think Stuart, do you want to say something, Stuart?
Yeah, I'm also an accredited fit tester like Paul, and my experience has been very similar. And I would urge any organization not to cut out fit testing. Some have, I won't name any names, and that is a dangerous move. But it was triggered for exactly this reason, a constantly changing supply of respirators. Now, there are other things I'd like just to mention, that maybe there are other options to consider if you can. So maybe one is to prioritize certain workers who are critical to certain functions, get them and prioritize them with their supply of respirators. Maybe if you're chopping and changing around, maybe if there's less critical to your infrastructure workers, maybe those are the ones you fit test repeatedly on different ones if you are forced to. Consider different types of respirators as well. So there are ones which are reusable, and I'm going to mention this again because it is linked to supply and this crisis, that there are types of respirator which are reusable. It does mean they need cleaning, decontamination between uses. But because you're not throwing them away, each worker always has a respirator. So once you've issued that to them, they've been successfully fit tested, then your supply chain, your supply is much more secure. And then there are, of course, respirator types which do not need fit testing. So if you have people who are critical to your delivery of healthcare services, or they can't get a fit with the respirators you have, or for other reasons like they have facial hair, there are some options of respirator which do not need fit testing. So it's not an easy situation. I would also say manufacturers like 3M, we're doing our very best to enable simpler fit testing within our product ranges. So where we have supplied maybe valved and unvalved versions, we're trying to do the work to see if there is a difference between them, and if we can avoid fit testing, refit testing your workers if you're moving within a family of products from the same manufacturer, in my case 3M.
Can I just add something on the reusable respirators? They're a good idea. They tend to fit much better than filtering face piece type respirators. But as with most PPE, they're not made for use in healthcare. So the instructions for decontamination of them in the context of microbial contamination tends to be normally fairly unwieldy and poorly applicable. A lot of them will just say, wipe with a gentle detergent. That's not really suitable. These will often have filters which can't be immersed. So if the recommendation is to immerse them in disinfectant X, then they will need new filters every time they go through that decontamination process. So the theory of reusable respirators is great. The practice is normally rather unwieldy.
There's hospitals in the US looking at the viability of this and showing a lot of benefits. Again, it's something we can debate for an hour. I think it's going to be a topic of further study and investigation. But reusable respirators, they do have a place. But yes, there are certain challenges around infection control. So yeah, it's something we're going to have to look at as an industry and as the healthcare infection control area as well, and balance the benefits against the potential disadvantages and see what we can do.
Thank you. Thank you. Dean, you're going to ask the next question?
Hi. Yeah, this question is very much around ventilation and improving patient flow. So some trusts have advised to block off their ventilation systems when treating COVID patients in certain patient areas. Others have increased their air exchanges in the aid of additional air handling units to reduce the viral load in the air and improve patient flow. What would you recommend? And is there any clever solution out there? I'm targeting this to Peter Hoffman and then Paul Humphrey.
Okay, I work for PHE, but for this meeting, I'm appearing in a personal capacity, speaking as an IPS member. First, a little bit about AGPs. They're a kind of legacy of SARS in 2003 that we are stuck with. In SARS, it was observed that there would be high levels of infection of healthcare workers associated with certain procedures, and the term aerosol generating procedure was coined. Now, it was only observed that healthcare workers were infected during these AGPs when they were in the immediate vicinity at the time of the procedure. That's not aerosol transmission as it would be, for example, with tuberculosis, where they found transmission, documented transmission over considerable distances. There is a very good review by Health Protection Scotland of the evidence behind AGPs. This is available online, and the highest category of evidence there was weak. So there's not that much evidence around about the nature of aerosols and their infectivity in the context of COVID. Microbial numbers are important in infection transmission. If you meet one virus, you're very unlikely to get infected. If you meet 10 million, you are very likely to get infected. And there's a huge grey area in between. If aerosols do play a role, then dilution of aerosols, reducing the numbers of airborne virus, is a vital infection prevention parameters. If you block off ventilation, you will stop diluting the concentrated aerosols, those aerosols that are in the immediate vicinity of production. Those are the most dangerous. The risk to the people immediately around the point of production. So don't block off ventilation. That will leave stagnant air. That will result in minimal dilution of the most dangerous aerosols. So the approach to COVID and aerosols is highly precautionary, but we're stuck with it. Increasing ventilation is good. If a room has existing mechanical ventilation, it's very unlikely that it will be able to increase to a significant extent. People don't spend lots of money unnecessarily in providing spare capacity in ventilation systems. So there are two possible options. There's adding natural ventilation in there, which in essence means opening a window. This is not practical for a lot of hospital premises, but it is practical for people like general practitioner dentists. So they can increase their ventilation quite a lot by opening windows. What we have is a situation where it would probably increase the effective ventilation rate to put in devices which recirculate air within the same space and pass it through something that cleans it up. This is normally either high efficiency particulate air, HEPA filters, or some sort of high intensity UV chamber. Now, there's an interesting set of frequently asked questions which are produced by NHS E&I estates. These should have been circulated. These are not available online, but they should have been circulated to healthcare estates departments. It's probably going to be a good idea if I pass these on to the organizer of the meeting and these FAQs are made available to the participants of this conference. So their frequently asked question number 12 is, should I turn off or turn down air handling systems, especially where it is positive pressure? And the answer is no, do not turn off or turn down air handling systems. Air changes will dilute and thereby reduce bioload. It is good irrespective of whether it's positive or negative pressure. An air pressure change in one space will directly impact all its adjacent spaces and can only be done following a full impact assessment. So the more air you have, the quicker the patient turnaround in any particular consulting room can be. Paul, did you want to add anything?
Yeah, I think where the confusion, may have come from is that traditionally when we think we've got people with an infectious virus, then we want that space under a negative pressure. So we're sort of sucking air out of that space. So the air is always coming into that room and it's not traveling out and potentially infecting other areas of the hospital. So that's been the sort of traditional approach. And I think another problem was a lot of hospitals have converted their sort of theatre complexes to sort of being COVID wards. And traditionally you have the opposite kind of pressure regime in there. You have a positive pressure one. So I think that's probably, caused estates to think, well, should I be turning this off or should I be keeping it on? Because obviously the positive pressure regime, you're putting a lot of air into a space, so it's really good ventilation, but then you're sort of forcing that air into other areas of the hospital the way it naturally works, because normally you've got a patient in there that is undergoing surgery and is very prone to infection. So I think that is where some of the confusion has occurred. And generally speaking, if you look at the advice from the HSC, from CIBC, who are kind of like the experts in this country, ASHRAE in America, and BESA in Europe, these are all kind of bodies that kind of advise on ventilation. They're saying, yeah, just have more ventilation, so increase the rate. And so, yeah, I don't know if anybody else has any views on that.
Okay, then we can continue with the next question. Thank you very much.
Thank you, Claudia.
So that is me, actually. Talking about FFP3 masks, we know that they are very, very uncomfortable. We've seen people suffering wearing these masks for hours. And we were wondering, are there any novel technologies which can improve the comfort of FFP3 masks? I know we have quite a few experts here. We have Alex, Stuart, and Paul that can all chip in and tell us something about it.
Who do you want to start?
I think for me, I'd like to challenge the question of they're all uncomfortable. And actually the question is why are they uncomfortable? And perhaps that's because of the unusual situation which we find ourselves in, or in that we found ourselves in, hopefully we're through it, in that we're looking at using a single-use respirator, which the HSC generally recommend should only be worn for 1 hour between breaks for an extended period of time. And I think some of the other challenges there, we have unaccustomed users in quite high pressure situations. So we have a combination of issues coming together around extended use, unaccustomed wearers, perhaps inappropriately trained as well, because we've seen poor fitting of respirators and incorrect fitting and things which would actually exacerbate feelings of discomfort. Now, I fully acknowledge that a respirator is uncomfortable. Any item of PPE creates a level of burden, but these respirators are actually packed full of quite advanced technology to give very high levels of filtration to air moving through them at very relatively high speeds, minimizing the breathing resistance, and in some cases minimizing the exhalation breathing resistance as well. So I think we need to look at it more widely than just point the finger at a respirator, but then of course I do work for a respirator manufacturer, and look more holistically at the application of a respiratory protection program in healthcare. But I do acknowledge there's things which could be done to make them better, but there are products which are more comfortable already. And again, we don't want to go back to the point. There are limits to what we can do and build into a single-use disposable respirator. We have lots of comfort features, and other manufacturers will have lots of other comfort features in items which are designed to be reused. And that brings us back to that reuse disposable debate. So I'll hand over to Alex or Paul.
Yeah. So it's Alex.
You want to go first, Alex? Yeah.
Okay, I'll just go. And I haven't got a lot to add to that. Yeah, I mean, obviously, the whole industry is very much focused on making these as comfortable as possible. This isn't something that's just appeared throughout this crisis. I mean, yeah, and I think as has just been said, really, you need to look at possible alternative approaches. Reusable masks, full face masks might be more comfortable, or even positive pressure type masks, which use a slightly different technology. The ones that don't need face fitting, but of course they don't provide protection for other people from the wearer. And again, we go back to this debate about how can they be effectively cleaned up. I think I have read some papers that talk about different sorts of sterilizing media that can be used on masks. I can't remember what the actual chemical was now, but I think there is some research in that area, particularly in view of the COVID crisis.
There's a lot of work in the US using vaporized hydrogen peroxide, UV, and other methods, varieties of steam sterilization. But again, should we be trying to decontaminate, because I don't want to use the word sterilize, but decontaminate an item which is designed for single use? Is that truly appropriate? Again, and going back to what Peter was saying, maybe a correct application is to work on centralized, provable decontamination methods for items of PPE which are designed to be reused and perhaps designed to be decontaminated. And those could perhaps give the comfort benefits we're looking for. And just to pick on you one point, Alex, sorry as well, you mentioned powered air, positive pressure powered air systems. Nobody's proven what they do or do not do in terms of protection for others. There is no standard or method or or proven data to show anything around there. And there are actually some researchers who have published recently suggesting that there is minimal or no risk. In fact, they actually are more protective than a surgical mask. Let's remember, a surgical mask is loose fitting. Air will spill from the sides of that mask and enter the atmosphere and the surrounding air unfiltered. So it's a very complicated topic.
Yeah, I think the intuitive thought would be that it'd be similar to a valve respirator, in that, you know, the air's coming straight out potentially.
Yeah, again, the largest droplets will probably impact the back of a diaphragm in the valve, but yeah, we don't know, to be honest, and that's another area of development. And remember, of course, we never expected this with asymptomatic patients and pre-symptomatic patients as well. So all of the stockpiles and a lot of the preparation from the PPE industry was based upon this scenario never happening.
So to add a few things there, I mean, FFP3 is a tight fitting mask. So by definition, it's going to be slightly uncomfortable, but that's how it works. That's how it forces the air to go through the filter. And that's what cleans the air. The contaminants stay on the filter if there's a good seal. Another thing that makes it uncomfortable potentially is the actual sort of breathing resistance. So it's harder to actually breathe when you're wearing a respirator. But obviously, the manufacturers are trying to reduce that as much as possible. Obviously, everyone has mentioned loose fitting as a potential other choice. And finally, there is innovation in sort of respiratory systems that's going on all the time. One that you may have come across that hasn't been proven, and I'm certainly not recommending it, but could be a solution in the future with regard to comfort, and that's kind of doing a kind of scan of people's face and actually coming up with a sort of 3D printed kind of seal region for that one particular person. So that would suggest it would be as comfortable as you could possibly make it. But I kind of do agree with Stuart to some extent that if you're going to sort of spend a lot of money, you'd probably be best to do it on a sort of reusable system and make sure that reusable system can be cleaned down and sterilized. And there are filters available now, just going back to that sort of question on the filters, that are encapsulated, so you can wipe the exterior of the filters, but the actual filter material itself is contained inside that encapsulated area.
Lovely, thank you very much. I think we'll proceed with the next question. I see we don't have a lot of time. Let's see if we can squeeze in a couple of more questions. Let's hope so, otherwise, obviously, we will have to close soon. So I'll hand over to Chris.
Thank you. So the next question really is around, as we get better with assessing staff, and particularly staff that are at risk, what do we do in terms of placing them in other areas where they can support and help? So the question really is around, you know, if you've got a BAME or a high-risk member of staff identified, would it be appropriate and acceptable to allow them to work in a COVID negative area? So we're assuming almost that you've got kind of a cold ward or a ward where there aren't patients that are known to be positive, at least anyway. We can't rule out the asymptomatic carriers in between testing, but you know, wherever possible, you've got someone who is asymptomatic and tested negative previously. I'd like to open up that question, please, in the first instance to Katie and then to Jenny, and then see if we've got time to squeeze in any other contributors, please. Thank you.
Thank you, Chris. I sort of feel that there are lots of questions embedded in this, and one in particular about, can we regard aerosol generating procedures in patients who are classed as being COVID negative as being non-infectious aerosols, and therefore can we be relaxed about you know, for not necessarily vulnerable patients, but actually relaxing our level of PPE from the respirators that we've been talking about back down to a surgical mask. And then also embedded within this question are questions about what procedures are aerosol generating. Personally, I don't think that insertion of an NG tube is an aerosol generating procedure. And we've gone through many months now of swabbing patients wearing a surgical mask and eye protection. But it's a personal view, but I think that it very much depends on population prevalence, what is out there, and that allows you to make a risk assessment of who's coming through your front door. Patients coming through your front door in an unassessed way are not going to be the sort of patients that Chris was describing in our sort of cold areas. So we're really talking about staff who are working with pre-assessed patients who've had, before they come into your work setting, they've probably had a phone call to make sure they're asymptomatic. According to the NICE guidance released yesterday, they probably won't have done 14 days isolation, but they probably will have had a swab done. And I think we can build up a number of factors that allow us to manage a patient as negative, and that makes their aerosol generating procedures also negative. And therefore, for our vulnerable staff who are being asked not to work in COVID-facing areas, I think it is reasonable for them to work in those areas and potentially to perform AGPs on those patients. But of course, the next question is, well, what level of PPE do they need to wear? Are they going to be wearing a surgical mask, or are they actually going to be wearing a respirator? And I think that's a really tricky question, but I would like to create an environment in our trust where we work where people feel comfortable if recognizing that not necessarily themselves, but others may be vulnerable and may feel comfortable only wearing a respirator, or what we call level 2 PPE, even if for the rest of the trust we're asking them just to wear a surgical mask. So I think we should be able to get to a position where we can regard an aerosol generating procedure as producing a non-infectious aerosol, potentially wear a surgical mask, but also have that respect for others who feel much more comfortable working with a higher level of protection. I think it's a difficult environment to create. It's going to need a lot of thought, understanding and respect for each other to do that.
Thank you, Katie. Jenny, can we please just have your views on this quickly?
Yeah, sure. And actually, I agree really with everything that Kate said. And I do think we're in an environment at the moment where many people, many staff have come through a really traumatic experience. Many of them moved from clinical areas into ITU, and I think it's created a very heightened and absolutely understandable sense of concern. I do think the problem with AGPs is that many things that patients do, or many procedures, generate aerosols. I mean, we know even coughing generates aerosols. It really comes back to what Peter was saying, and it's about high risk aerosol generating procedures. So there will always be a certain amount of aerosol, but it's that association between procedures that produce so much aerosol and are such high risk that they indicate the need to use a higher level of PPE. And I think that's where a lot of the problems come around in terms of clinical groups being concerned about procedures they do that generate some coughing, and then seeing those as aerosol generating. And I think that there's now some work going on with NHSE to try and tackle some of those problems.
Thank you, Jenny. At this point, I'd just like to ask if any of the other panelists would like to add anything further. We've had quite a comprehensive response so far, and I think we all appreciate that it is quite difficult to make these sort of contained environments and this movable feast that we are finding ourselves in, for want of a better way of saying it. The pandemic has put quite a challenge out there in terms of managing staff capacity, ward cover, etc. And I think some of us can really relate to that, particularly in hospital areas where the acuity has been really, really there, but also in community where staff have been quite sparse. And it's been quite difficult to cover gaps in service. So that's it's a difficult question. I get that, but do we have anyone else on the call in terms of the panel members that would like to respond to this?
I think, Chris, we are hitting the 8 o'clock. I wonder if the panelists would agree for one more question, because I think the next question, there's a few of us officers we really would like to hear an answer to. If you need to go, we will understand, and we're really grateful for your input today. I think it really seems that this event has been a success. Thank you. Am I allowed to ask for one more question?
Go for it, Claudia, because people are free to leave if they want to.
Thank you. And Jojo was going to read it out for us.
I thought you were just completing this one for the last one. Anyway, thank you. Yeah, just going back to the issue of the 72 hours in terms of objects that cannot be decontaminated, such as papers, drugs that are returned to pharmacy, any an open single-use item, etc. Do we really need this? I think the panelist is for Jenny Wilson and yeah.
I would suggest you ask Peter Hoffman to answer this question.
Okay.
Thanks, Jenny.
My pleasure.
Oh, no, it's Martin as well. Sorry, it's Martin and Alex and Peter probably. Yeah.
Okay, shall I lay some groundwork? Things are going to get contaminated by contact. Not so much the dropping out of aerosols, but more contaminated gloves making contact with surfaces. Nobody really knows whether or not, or the degree of significance of these in possible transmission, but the numbers of viruses could be quite high in comparison to aerosols. But then the viruses have to get onto a susceptible person's mucous membranes in order to infect. So this is an extrapolation of rather poor, but that's all that's available, laboratory data on coronaviruses dying off. If it's feasible, it's probably a reassuring safety measure, because we can't say that these items are not safe as soon as they come out of a COVID environment.
Okay, shall I dive in?
Go ahead, Martin.
Okay, so I think that's Peter's nicely summed it up. There's a couple of parts of this. You know, how long the viruses retain viability on the surface, and that's really variable, and that's dependent on how porous the surface is. So how quickly do they dry out? The environmental factors like the temperature and the humidity, and the virus envelope characteristics. So okay, we're dealing with a non-envelope, an envelope virus here, so that survives less well in the environment than envelope viruses. You know, temperature and humidity can be variable. We know that some of the surrogates survive very well at high humidity, some don't. Temperature, non-porous surfaces, you know, okay, you might have something that's paper, but parts of it could be plastic, and we know that these viruses survive very well on plastic surfaces, but not so well on paper and cardboard, and really badly on things like tissue, where they dry out very, very quickly. And then you've got to look at what might become contaminated in the room. As Peter said, it's probably not the aerosol. It's probably more likely to be that, I'm afraid our hands go absolutely everywhere. But if you look at most of the even poor laboratory papers, within a week, it seems to have gone. So to be honest, I think there's probably bigger battles to fight than just say, do you know what, we're just going to quarantine this lot for a week, and then it should be absolutely fine, just as a reassuring measure. And just bear in mind, we do not do anything like this for norovirus, which we know survives better in the environment than things like these coronaviruses. So, you know, I think we've got bigger battles, to be absolutely honest. And, you know, just save it up for 72 hours. Minimize what you can going into the area if you can, but if not, you know, 72 hours is reasonable. I mean, at the Nightingale, we used a London hospital's policy, and I won't name it, but their policy was to bag things up for 7 days. So I thought that was a bit over the top, but that's probably, I mean, we know it's okay anyway. And if you don't need to touch it in that time, if you're not desperate for it, then really what's the problem, to be honest? That's my view.
Thank you.
Alex?
Yeah, just very quickly, I was haven't got a lot to add to that. I guess if something is really urgent, it becomes an issue, do a sort of risk assessment, and if you can put a fresh pair of gloves on and do what you need to do with it, I guess there could be ways around it if that becomes an absolute necessity. But yeah, I think I agree generally. If it's not a big deal, then yeah, it doesn't hurt to take that precautionary principle, if you like. Yeah.
Thank you very much, gentlemen. And I think I'll hand it over to Dean.
Hello, everyone. I just wanted to say thank you so much to the panelists. Thank you for participating and contributing your expertise this evening. And to everyone who joined in, who submitted questions. We'll also be sending questionnaire out to everybody who participated today. And we'd also like to send a link for membership for the Infection Prevention Society. There are some members people that joined in that weren't members, apparently. So thank you so much for your contribution this evening. And we really value your time and your expertise. Very grateful. We realise that everyone's working in their own time.
And can I just say, on behalf of the Society, thank you so much to the North London branch for organising this event. I think you've done a fantastic job, so really well done.
Thank you.
Thank you, Jenny.
Thank you, Jenny.
I think we're going to close. Thank you so much.
Thank you,
We'll
Claudia.
look
Again,
forward
everyone.
to the next
Bye.
event.
Bye, Claudia. Bye, everybody.
Bye.
Bye.